Um, so I kind of stole this collage from our previous a conference we had earlier this year. So it kind of gives us a little idea into how big our team has grown over the past several years. But we need a team approach to approaching medical weight loss. And I myself, and I can echo a lot of my colleagues, approaching medical weight loss requires approaching it from many different angles. And I'll get further into that as I go along in my lecture here today. So I'm going to start today, our talk today, with a little bit of a background about metabolism and weight gain. So if there's anything to take away from today, it's that obesity is complex and complicated by many factors. So these include genetics, epigenetics, the environment, which influences our choices, the immune system, the endocrine system, and the fact that neurobehavioral actions, they all contribute to our body composition. They're all important things to acknowledge. So what we know about weight is that there are numerous genes and hormones involved with weight gain. But what we also know is that just because we have these genes and hormones, it does not necessarily mean that you will become overweight or struggle with weight in life, but rather it's a complex interaction of these genes with the environment, which leads to hormonal and biological changes. So it all starts even before we are born. So we know that whatever happens in the womb can affect with how we deal with weight in our life. So there are modifiable prenatal factors that are associated with childhood obesity. For example, a mother's smoking habit, a mother's weight, or the mother's weight gain that she has during pregnancy, pregestational or gestational diabetes. They all play a role in weight gain. And then there are some modifiable postnatal factors associated with childhood obesity as well. Things like a rapid weight gain that a child might experience during the first 6 months of life. Mothers who are unable to breastfeed or who had a short duration of breastfeeding. All of these things are things that we have seen cause a child to have more challenges with weight as they grow. Um, Even things like an infant's sleep duration, where they have an infant sleeps less than 12 hours during the day, had doubled the odds of being overweight by the age of 3. Later in life, other factors play a role. Things like pregnancy, age, menopause, I see a lot of the time in my clinic, life-changing events that occur in our life as we get older, job changes, marriage, divorce, having a sedentary job, medications. A lot of the medications that we take are weight-promoting medications, things like steroids or some of the diabetic medications that we most of the time we think are weight losing, but a lot of them are weight promoting medications. Illnesses, any sort of stressor on the body, illness, surgery can be a weight promoting event in our life. Stress, quitting smoking is a thing that can help promote weight gain. Sleeping patterns, alcohol, all of these things are factors that can promote weight gain. The environment also affects weight gain and weight loss. Sometimes this can be toxic, surrounding us with unhealthy foods. Sometimes it's the social norms that we experience every day. The environment that surrounds us plays a big role in our food choices and activity level. So we're all very familiar with the behaviors that play a role in our weight loss journey. Unhealthy diets, processed foods, sweetened beverages, fast foods that are easily accessible, eating patterns such as nighttime eating, binge eating, and stress eating that a lot of us do because of comfort, lack of exercise, or even lack of sleep or too much sleep. They find that people who sleep less than 5 hours or even sleep more than 9 hours a day actually tend to weigh more. Sedentary behaviors, screen time, our work schedules, all of these things actually impact our weight loss journey. Mental health, that's another big player in our journey as well. Um, So what we know is that when individuals who are not well supported with any mental health illness from which they might be suffering from, weight loss becomes even a bigger challenge for them. So, well, how do we know this? Because we've seen, for example, depression leads to emotional eating, which then leads to weight gain, which then can lead to body image distress, further exacerbating depression. So it's a vicious cycle, and it's important to treat that alongside with weight loss to help maintain weight loss in the long term. And then what about insulin resistance? So we've seen that term thrown around a lot recently. Does insulin resistance lead to weight gain? And the answer is kind of yes. So you've probably seen this term thrown around a lot. So what does this term refer to? So this refers to the body's response to an elevated storage of fat in the body. So when you eat, your digestive system breaks down the sugars in your food and then releases them into your bloodstream. The rising blood sugar levels signals your pancreas to secrete a hormone called insulin. So insulin is responsible for a couple different things. But what you should know is that it's involved in helping us store fat in the body. And when insulin resistance occurs, there arises when the insulin receptors kind of become dysfunctional in the body. So over time, this increased demand for insulin exhausts the pancreas. And at the same time, this excess sugar that lingers around in the bloodstream gives rise to various health complications. And then the patient experiences this. You don't feel well. You feel tired. You feel hungry. You feel unwell. And eventually, all of this can become a contributing factor in weight gain. So eventually, insulin resistance progresses to a point where it becomes something called diabetes. So how do we stop this cycle? So with the right lifestyle changes, weight loss, and perhaps some of our medications, we can help halt this progression of insulin resistance and maybe even fully reverse it as well in the future. And then you've heard a lot about the weight regulation hormones as well. So I'm going to kind of go into detail about a couple of hormones today. So I'm going to talk about the two main hormones that we talk a lot about in my clinic as well when patients come to see me. So I'm going to talk about the two main hormones, leptin and ghrelin. So leptin and ghrelin, those are two opposing hormones. Leptin is the satiety hormone. It makes you feel full. Ghrelin, the opposing hormone, is the hunger hormone. It makes you feel hungry. So the hormones that regulate our appetite and food intake, they're actually located in the brain. So when we have a high fat, high carb food intake, it actually impacts how our appetite regulation system works, making it inefficient. And as a result, those hormones don't get communicated to the rest of the body, specifically the stomach. So the stomach is where there are signals to sense fullness. So leptin is created by the adipose tissue cells, which are fat tissue cells. So one of the things that we have noticed is in individuals who are overweight or who have challenges with weight have high levels of leptin that have become resistant. So the term is leptin resistant. Ghrelin, which is the opposing hormone on the flip side, ghrelin makes you hungry. So it's located in your stomach. And what we know through research is that a high fat, high carb food intake actually triggers the ghrelin hormone, making people feel hungrier. So you may have heard of the term carb leads to more carbs. So what happens when people have a weight loss of 40, 60, 100 pounds? We know that there's a decrease in the fullness hormone, specifically the leptin hormone, making you feel hungrier. So physiologically, it's very challenging to maintain a weight loss because of these interplay of these hormones. So that's kind of where medical weight loss comes into play because we've understood this balance of hormone that occurs, and we use our medications to help kind of use this information, this knowledge about these hormones, and how can we use our medications to our advantage to help us control some of these weight regulation hormones that have occurred. So, sorry about that. Let's go back a little bit. So let's now enter into the world of GLP-1s. So that's specifically what I was asked to talk about today. So there's a lot of information out there. It's a pretty hot topic nowadays. But I'm going to try to touch base about the basics about them for you guys today, so you guys have a little bit of a better understanding about how they fit into a comprehensive weight management program. So when do we use pharmacotherapy? So this is not just for GLP-1s, but for most of the medications that we use in our program. So we follow the criteria that I have listed out here on this slide. So we use medications for anyone who has a BMI above 30 with no comorbidity. And we use medications for patients who are above a BMI of 27 with some sort of comorbidities. So comorbidities is something like having high blood pressure, diabetes, high cholesterol, sleep apnea, or some sort of other more drastic comorbidities, such as like a heart attack, stroke, fatty liver disease. So what is a GLP-1? So let's go back to the beginning and let's figure out what GLP-1 stands for. GLP-1 stands for glucagon-like peptide 1 hormone. So it's actually a naturally produced hormone in our body. It's made in the gut after eating, and it helps us feel full. So it plays a key role in regulating appetite and blood sugar regulation. So a GLP-1 medication is one of many medication options that we use in our arsenal of tools to help us battle weight, but it's used as an adjunct to the other tools that we mentioned of diet and exercise. It's a powerful tool for people who are suffering with chronic weight management, but you have to meet the criteria, but it's also, we want to make sure you guys use it safely. So, and I'll go more into that as well. So what exactly does it do? So there's three main activities that a GLP-1 is responsible for. So number one, it signals the brain to tell us we are full. So even while consuming fewer calories and promoting weight loss, it acts in the hypothalamus in the brain to increase satiety. Number two, it decreases gastric motility, so helping patients feel fuller by slowing down the gut. And it slows this down, which helps also further increasing satiety after you eat something. And then number three, it goes back and tells the pancreas to release more insulin, which improves blood sugar and insulin sensitivity, which then is very helpful in our diabetic patients, which is what this medication was originally made for. And so patients with diabetes, prediabetes, or insulin resistance, it's very helpful in those patients. So kind of doing double duty for them. So there's two main GLP-1 medications on the market right now and there's more in studies, and I'll get into that in a minute. So there is semaglutide, and then there's something called tirzepatide. So what's the difference between the two of them? So both of them, semaglutide will start working in about 4 weeks, and tirzepatide will start working in about 4 weeks as well. In studies, semaglutide shows about a 15% total body weight loss. Tirzepatide shows a little bit more weight loss in studies, about a 20% total body weight loss. Semaglutide works on the GLP-1 receptor alone, where tirzepatide works on two receptors, the GLP-1 plus a GIP receptor, in addition to the GLP-1 receptor. In head-to-head trials of both of these two medications against each other, in something called the SURMOUNT-5 study, they did show a little bit more advantage of the tirzepatide, showing a little bit more weight loss, especially in type 2 diabetic patients. But still more data is needed to show if there's actually more efficacious weight loss seen between the two medications. And then Beyond the weight loss effects, we have seen some great benefits of the GLP-1 medications to benefit the patient beyond just the independent weight loss effects of these drugs. So a major breakthrough was seen with the SELECT trials. That showed that individuals with obesity and established heart disease, semaglutide was able to reduce heart attack risk stroke, reduce the risk of heart attack, stroke, and cardiovascular death, as well as improved heart failure risk in patients with such symptoms. So in March 2024, the FDA approved the use of Wegovy for the use of these medications in these high-risk individuals. So they were able to use these medications to benefit from weight loss along with cardioprotection of these medications. So newer studies are coming out as well, showing some neuroprotective effects of these medications. So patients with like dementia might be able to use these medications in the future, but these are in beginning stages of studies, so more to come on that in the future. And then the more recent studies have come out for GLP-1s for trials of patients with fatty liver disease, which are very promising. So in August 2025, semaglutide was approved for the use of patients with non-cirrhotic steatic hepatosis for prevent the disease progression of liver fibrosis, and that was based on the ESSENCE trials. And then you've heard a lot about tirzepatide being approved for patients for obstructive sleep apnea. So the SURMOUNT trials were done with tirzepatide, and they have shown significant improvement in patients who have OSA or obstructive sleep apnea. So the FDA approved the use of Zepbound for moderate or severe sleep apnea in December of 2024. So poor sleep from untreated sleep apnea disrupts hormonal balances that regulate hunger and satiety, kind of what I touched on before. And this leads to increased caloric intake. And then research has shown that sleep deprivation causes individuals to consume approximately 300 to 900 additional calories daily. So this further exacerbates obesity, further exacerbating obstructive sleep apnea. It's this harmful cycle that makes sustained weight loss even more challenging. So in the article published by the New England Journal of Medicine showed that tirzepatide was significantly reducing sleep apnea severity by achieving remarkable weight loss. Specifically, the medication was able to decrease 59% of the AHI, which is the apnea-hypopnea index for OSA. So showing improvements in blood pressure, systemic inflammation, overall sleep quality, which is why it got the approval for sleep apnea use. So how do we take it? So for the patients who are started on it, so I'm just going to go through some like semantics of the medication. How is it given? So it's a once weekly injection. And where do we give it? It's usually given in the lower abdomen, about 2 inches away from the belly button. At least sometimes it's given in the upper thighs. Some people can use it on their posterior upper arms as well. So we always start at the lower dose and titrate up as per your provider. We usually titrate up about every 4 to 12 weeks, depending on your response to the medication, obviously side effects of the medication. And we don't necessarily need to always increase to the higher dose to see results of the medication. So that you work on with your provider. Side effects. There's always a price to pay with side effects of these medications. So usually the side effects are mild, temporary. They often resolve within the first few weeks of the treatment. The most common side effects are nausea, and that's due to the feedback mechanism from the gut to the brain of the medication. And that can be managed by avoiding strong smells, sometimes eating like, a little bit of carbs, crackers, mint, ginger-based foods, drinks, avoiding drinks about a half hour after taking the medication. I've also often found that like protein loading the day before you take the injection also helps patients out a lot. Vomiting, not really seen that often with the medication. It's more of the nausea effects that I see with the medication. But also can be managed by staying well hydrating, having more frequent smaller meals can avoid some of those side effects. Diarrhea, that can be managed by drinking plenty of water, avoiding dairy products. Sometimes the high fiber foods can help prevent some of that as well. Constipation, that one is probably something I see more than I see the diarrhea. And that's due to the mechanism of how the medication is working. It's really slowing down your gut. So that's why we kind of really hone in on making sure you're getting your fiber content while you're on this medication. Um, Making sure you're getting your water, heartburn, stomach pain, and injection side reactions. You want to make sure you change sides every week you're taking the injection. So to obviously avoid these side effects, you want to eat slowly, you stop when you feel full on these medications, you're having smaller portions, and you want to avoid being too active immediately after eating when you're taking these medications. Um, Less common but more serious long-term side effects of these medications include things like what we're seeing more recently, I should say, now that we have more patients on these medications, is muscle mass reduction. So if you're not exercising well on these medications, what we do is really want to watch your muscle mass while on these medications. So in our program, what we really emphasize is a holistic approach to weight loss, including a good diet, a good exercise regimen. We watch your muscle mass on these medications. And then further down the road, the longer you're on these medications, the we want to make sure you're not muscle wasting on these medications. Bone density loss is kind of secondary to that muscle loss that we want to watch as well. Weight rebound. So weight rebound can occur. What we've seen a couple different scenarios for this. But in the case of coming off a GLP-1 or not transitioning correctly to another medication or not having a proper diet and exercise regimen when coming off a medication, these are things that you have to discuss with a weight loss provider who's kind of well versed in how to come off a medication properly or how to transition you off the medication properly. Pancreatitis, I think that's a word that kind of scares people a lot. So obviously we're going to screen you for history of that before we start you on a medication. It's rare, but it can be dangerous. And that word means it just means that your pancreas is super inflamed, right? So obviously it's a contraindication to be on the medication, but we'll screen you for that before we put you on the medication. Gallbladder inflammation can also occur, but that's usually when weight loss occurs too quickly. So obviously we're going to watch you to make sure you're moving at the correct trajectory on the medication. Gastroparesis is when the gut slows down too much. And then thyroid cancers are rare. So there's specific thyroid cancers that we watch for, especially if a family history or a personal history of thyroid cancers. And that's one of the things we also screen for before we start a medication. And who should not use medications? Like I said before, a history of thyroid cancers or men too, any history of pancreatitis, patients, women who are having pregnancy or planning on having any sort of pregnancies in the near future, known gallbladder disease, any history of retinopathy, really should be consulting with their ophthalmologist before starting these medications, a history of gastroparesis, and then patients who are on insulin or other glucose-lowering medications, patients who are diabetic. We want to make sure we work with your endocrinologist or your primary care doctor before we start these medications for you, just to make sure, if we're piling on another diabetic medication on top of your other medications, that we adjust your other medications before we add on this one as well. And then, no, currently, as we look forward, there's actually other GLP-1s that are going to be coming out soon. I'm sure you've heard about them. There's about 170 other medications in the pipeline that are being studied for weight loss. So don't worry if you're like, I've tried a GLP-1 and it didn't work for me. There are others being studied, and most of them are GLP-1 based, but they've combined them with other receptors along the GI tract that are trying to figure out what can we combine, what other receptors can we combine to see where we can get more maximal weight loss. But we're also trying to see, hey, can we mitigate some of these other side effects that we've noticed with the current GLP-1s that we are on? And so we're working on that. So one of the main challenges in weight management is the inability to predict a patient's response to the medication. And with the wide variabilities in individuals' weight change in response to a given medication, these future studies are looking into how do we mitigate these challenges. And so that kind of brings me to the end of my presentation here. So I hope I'm going to leave you guys with some takeaway points. So weight loss is a journey, right? We want to make sure you focus always on some small, steady changes. Swapping out things and your everyday life is where you're going to see the most biggest changes at the end of the day. Things like changing a small part of your meal, getting a little bit more sleep, getting that extra 10 minutes of exercise. These are little things that are going to add up to a big impact at the end of the day. Pay attention to your mental health. That is an important part of your weight loss journey. As much as we want to get everything done, but your mental health is actually number one in this whole journey. Think long-term goals. Like quick fixes are really rarely going to last for you. Aim for habits that you can maintain, not drastic changes that just feel unsustainable. And while medications are readily available, and it seems like they're everywhere, really look to your medical resources for help. When the medications are used correctly, under medical supervision, they are a lot more advantageous to your goals. And remember that these medications do not replace a healthy lifestyle. Weight is only one piece of the health. Connecting the dots of all the complicated, dreaded diseases, that is what we're trying to avoid, which is metabolic syndrome, right? And its adverse health consequences. So what we're trying to do for our patients is use these medications with healthy lifestyle and be able to get our patients to live a healthy life without side effects, long-term complications, and decrease their risk of metabolic risk in the future. So I hope that gave you guys a great kind of overview of what we do at our program and kind of how GLP-1s kind of fit into a comprehensive program, but it gives you guys a little bit of idea of what GLP-1s can do for you guys. So I will end my talk here and I'll open up for any questions that you guys might have.
Dr. Sheikh, I do see a question in the chat. It's asking, is GLP-1 good for people on the bubble with BMI of 27, which is where I'm at as a result of multiple surgeries, torn muscles. I put on some extra weight that I'm having a hard time dropping. So I think it's really asking if a BMI of 27 is an appropriate place to be to consider a GLP-1.
Yeah. So I always kind of like look at it as you want to look at the whole picture of everything, right? So a BMI of 27 is a little bit of like that. It's like on the fence, right? So we always want to, so in our office, we actually have something called a Sika scale, which looks at your body composition. So I always look at it, we look at your body composition, we look at your fat mass, we look at your muscle mass, and when we can decide whether or not a GLP-1 is really safe in that situation. Um, if we feel like, and then I look at your history as well, the surgeries itself obviously could put you at a higher risk of all the kind of like bad side effects of the GLP-1s, but perhaps your fat mass is high enough and we can mitigate some of those risks with getting in a good nutrition plan, getting in a good diet and exercise plan for you. And if we keep you on a low dose of a GLP-1 plus the diet plus the exercise, it might be a good option for you. But say, for example, you might have some other, you know, past medical history, it might not be the best idea for you. I mean, I would have to look at your past medical history, but that's where we would sit together and figure that out together and make a shared decision making um,
Awesome.
to figure that out together. But if a GLP-1 is not the best decision for you, obviously we have other medications that we could use that could give you the same results. I think a lot of my less than 30 BMI patients could definitely benefit from another oral medication that could give you similar results to GLP-1's weight loss results that we see in patients who are higher BMIs.
That's great, Dr. Sheikh. Do you have a few minutes for a few other questions? Awesome. The next one is, do you have any information on GLP-1s in pill form?
Mhm. Yes, so the pill form is very similar in weight loss effects as the injectable. So semaglutide is the pill form. So basically, Wegovy came out with the pill form of its injectable medication. So that's currently the only pill form we have of right now. The only difference, what we know from what I know from the company, is that there's just, as far as side effects go, they has a little bit more GI side effects. But then the offset is that you don't have to take an injectable anymore. So patients prefer that. I think a lot of my patients who are scared to take the injectable are now like, hey, I could take a pill form. Um, the pill form requires you to take it every day. And you take it 30 minutes before you eat or drink anything in the morning. So for patients who are, let's say, on a thyroid medication, you would take this medication 30 minutes on an empty stomach before you would even take like your thyroid medication. So you would have to like set apart the timing of that as well. But the weight loss effect is about on par with the injectable.
Awesome. Next question. What happens after the 15 or 20% weight loss? What if you still need to lose more weight?
So then we're talking, so most of these GLP-1s, the ones that we have today as of 2026, yes. So 15 to 20% weight loss. I have seen more than that, right? So that's where, once again, body composition comes into play, right? So when I see in my office someone who has reached more than 10, 50% weight loss, I kind of stop paying attention to weight. Then I start paying attention more to muscle and fat mass, right? So if you think about it, muscle weighs more than fat, right? And so at a certain point in time, as you gain muscle and lose fat, you're changing your body composition, so it might seem like you're not losing weight, but you're gaining muscle weight and losing fat mass. So goal fat masses for males and female is different. And so as we're trying to lose more weight, and forgive me if I feel like I'm not making sense to you guys, but we're losing fat mass, not weight, if that makes sense to you guys. So that's why we follow the body composition more in my office, not necessarily the weight on a regular scale. We follow fat mass composition. Tell me if
I
that,
think that's a good
yeah.
condensed
And then,
explanation.
so for like my higher BMI patients, and there's a second part to the answer to this question. So for my higher BMI patients, so let's say if you're like a 40, 50 plus BMI patients, you still probably need more than a 20% weight loss. I completely agree with that. And then we're going to talk more about surgery. So if, as of right now, the gold standard for anyone looking for more than a 20% weight loss plus more than like, 25, 30% fat loss, then surgery would still be the answer for those patients.
All right. Do you see any issues with someone that has Hashimoto's disease and taking a thyroid supplement?
You mean along with like a GLP-1? I don't,
Yes.
there's no contraindications for those at this time.
Excellent. Here's a follow-up question. Is it a long-term thing, or is after dropping weight, if you stop and are eating healthy, sleeping well, and exercising regularly? So I think they're asking, do you have to stay on it, indefinitely?
Sure. Um, so the answer to that is kind of personal preference. I do have some patients, I'm not saying all patients, but I do have some patients who were able to kind of reset the body set point. And I'm saying short term for them was about a period of 2 years. However, step, I want to say step four trials of Wegovy have shown that once you stop the medication, most people do regain weight. So what their trials have shown that once the patient reaches about a 15 to 20% weight loss, we think of the medication as like a weight maintenance medication. So we use the medication to help you lose weight, and then we use the medication to help you maintain weight loss. So that's why we say we don't necessarily need to be on the highest dose for weight maintenance, and we could help you, be on a lower dose for weight maintenance. I have some patients who don't even take the medication every 7 days. We spread out to every 10 days. You work with your provider to figure out what that dose is for you. But a lot of patients do regain weight once they stop the medication. So we do think of the medication for weight maintenance as well in the long term.
Okay, maybe a few more. I accidentally skipped over a question that asked about microdosing.
Um, so that term has a lot of different meanings.
Anybody on Facebook sees those pop
Yeah,
up, right?
we don't really follow that in our practice. I don't think that's a real thing that we really do. So I'm not gonna really speak to that because it's not something we really do in our practice.
Okay.
Yeah.
Let's see here. If you are a breast cancer survivor, is it safe to take GLP-1s?
Yes. So yes and no. Definitely, we always work with your hem-onc doctor. There are certain chemos that interfere with GLP-1s. So obviously, we're always going to check interactions before you start that GLP-1s. If you're like done with chemo, then post breast cancer survivors, they do fine with GLP-1s.
Okay. Similar question about being a cervical cancer survivor, if it's safe to take GLP-1s.
Same thing. Yeah.
Okay. Do you have time for maybe another?
Sure.
Okay. Let's see. Somebody's asking about the cost.
Yes. So out-of-pocket expenses, I mean, you can look on their Wegovy website and the Zepbound website. All the prices listing there. As far as out-of-pocket expenses, I can say over the years that I've been practicing, these are the lowest costs I've seen, and I think most patients are pretty happy about the costs, but you can look it up on their websites. It's all very black and white, plain there. You'll see it.
Yes. And there is, this is just my own, I guess my own feedback. There are certain conditions that would make somebody eligible, correct? With their insurance, their medical
Yeah.
insurance.
If
Okay.
your insurance covers it, you can use like the coupon code to get it. Yeah. So any like our team will work with you. And we can always get you the obviously we do everything. So we'll choose your insurance, we'll do the out-of-pocket. We have prior auth specialists on our team because we do this all the time. So we'll figure out the cheapest way to get it for you as well. But yeah, we work with everybody. And then,
Okay.
yeah,
This is an
or
interesting question. All right. This one says, I see a lot of noise on social media regarding tight fascia or the need for lymphatic drainage. What is this?
so if they're talking about like post-surgery procedures, is that what they're talking about? So
Mhm.
there's something called loose skin that can occur status post weight loss, and that can occur whether you do it via medication, via normal weight loss, via surgery. But those are just types of procedures patients can do after surgery, after any sort of weight loss. So um, those are just types of procedures that can be done, and those are things you would talk about with a like a plastic surgeon.
Okay. And I think I'll just do one last one, and then anyone else that has specific questions, Dr. Sheikh, if I get those over to you, do you
Okay.
think maybe,
Yeah.
okay, so we can certainly circle back with Lydia with some answers to anything that wasn't addressed. The last question here is, can a family doctor give a prescription for a GLP-1?
Yeah, as of right now, totally. Yeah. So just make sure your family doctor probably has a little bit of knowledge about this. I mean, I myself was a family medicine doctor before I ended up becoming specialized in board certified in obesity medicine. Just make sure they have knowledge and know what they're doing. And then yes, any family doctor can do this as well.
Excellent. Great. Lydia, I don't know if you have anything else to add. I was thinking as a takeaway, I can certainly get Dr. Sheikh's information and program information over to you, Lydia, for anyone that might be interested in reaching her practice. Also, you guys can shoot Lydia an email with any additional questions that maybe Dr. Shea can answer and I can send those off. But am I missing anything?
I think we're all set. Thank you so much for hopping on this call and providing some great information.
Excellent. Thank you so much for having me. It was my pleasure.
Thank